manage hospitals, and those are the hospital boards that have decided that they are doing just fine from an independent standpoint, but they need all the resources that we can bring in from the C-suite to all of the different departmental resources that we provide. Mike already mentioned our LTAC, our long-term acute care hospital area. That is one that's really been growing a lot. As you all may know, from an LTAC standpoint, those are hospitals that are patients that are very ill, that have to be in a hospital more than 25 days. And they may be in an ICU on a ventilator, and they can be treated in a less costly, yet still very intense kind of setting. And that's really what the LTAC is. Hospital lease. We do have 2 of our 6 hospitals that we are the corporate member of are leased relationships, whereby we lease the facility from the taxing district or the taxing authority. We run those hospitals just like the hospitals that we're the full corporate member of, but that's that lease kind of relationship when there's a governmental entity like you all. We'll talk about some examples of those. And then hospital corporate member substitution. That's when a hospital board comes to us and says, you know, we really don't want to sell to an investor-owned because we really don't want to give up that kind of community control. But we need an organization like CHC that can provide all those resources and help us be more successful. So that's when we go in with a not-for-profit, a 501c3, and become the corporate member of that organization. So that's sort of the continuum of different services that we do provide.
Cindy, with your permission, can I just add?
Absolutely.
See, you knew I'd do it. We have to report to somebody as well. So we have a corporate board of directors. The IRS mandates, because we're a tax-exempt support organization, that 51% of those we report to have to come from the boards of those hospitals that we serve. And so that's the check and balance. We can, at the corporate level, spend a lot of money or do a lot of different things that don't make sense. Because the folks, we just had a weekend retreat with our corporate board. We have 12 members on our corporate board. They're representative of those institutions that we serve, making sure that we continue to support the hospitals as our IRS designation would mandate.
All right. Now here is a picture of the organization. And I will walk you through this. You know how Mike was talking about the flower pot? Well, down here at the bottom, let's see if you get this right here, here's the pot. That is CHC as a 509A support organization. And these are the hospitals here. As an example, those would be the hospitals that we are the corporate member of. So what happens with a governmental entity, which is up here, which would be like the taxing district? Basically what we would do with the hospital is create a new 501c3 not-for-profit organization. That not-for-profit organization we would be the corporate member of. Then the 501c3 hospital would lease the facilities from the hospital district, and the hospital district would have a relationship, enter into here an operating or a management agreement with CHC.
And that's what you pay for. It's just that fixed amount management agreement with CHC.
Right. Okay? Now, here's the real beauty of this kind of structure. Each of the individual hospitals, we don't blend funds. Each hospital maintains their own funds, their own financial statements, etc. And so what that means is, let's say one of these hospitals, this one over here, let's say this one's not doing so great. Well, none of the resources from the hospital that's successful shoots over there to the one that's not successful. Basically, they all operate independently. Now, the flip side of that, if we have a really highly successful hospital, those funds aren't taken to another hospital either. They're all very independent. Each of them has a fiduciary governing board. They do, as Mike said, the governing board is made up of local folks. We believe very strongly in having physician representation on the governing board. And we always have one CHC person that is also a representative on the board. So we try to keep as much local control as we possibly can. Now let me talk about this box that's over here called Tertiary Medical Center and affiliate relationships. Many of our hospitals decide to have a relationship with a tertiary hospital for referral relationships, for clinical education, perhaps for assistance with ER transfers, assistance with air evacuation, etc. And it doesn't necessarily have to be just one tertiary partner. There could be a reason why there would be multiple tertiary partners. For instance, a tertiary partner could be Memorial in Lufkin. There are some things that a tertiary partner could help you do from a physician recruitment, specialty placement, other things of that sort. We will talk with you about a case study in just a few minutes where one of our hospitals close to Austin looked around and said, you know, we really have a need for a tertiary in Austin, and they've created a relationship whereby there's clinical education. The nurses that are at the local facility go to Austin for training. There's some quality connection that's made there too. So the affiliate relationship with a more tertiary facility can be very flexible, depending on what it is specifically that the hospital needs.
And if I can add again, Cindy, one of the benefits of that formal relationship with a tertiary partner is you could go out and you could say, let's have a relationship with X, Y, or Z organization. But what we like to do is enter into an operating agreement or some type of shared services agreement where there is actually some specific things for that tertiary institution to do for your local institution. In other words, if in fact there's a recruitment opportunity for whatever type of physician, you know, sometimes that tertiary institution, by virtue of being the beneficiary of some of those transferred patients, will agree to recruit those physicians. If in fact there is an opportunity with nearby clinics to take those physicians that are recruited for your community and to actually manage them within the management structure of a local nearby institution. But that's all documented. There are performance criteria that tertiary institution has to enter into to maintain that relationship.
Okay. We obviously have really close relationships with Trinity Mother Francis in Tyler. We manage their hospital in Winsboro. Mother Francis has basically said, we're really good at the big stuff, but the smaller hospitals maybe not so well, so they've tapped into us to manage that facility. And then obviously we've got a really fabulous relationship with Memorial in Lufkin, Livingston, St. Augustine. So there are certainly options for tertiary providers to come to the table. Let me just say these are our consulting resources to let you know a little bit about the depth of CHC. In total, we have 67 employees. Some of those are at specific facilities. We've got about 42 that actually go and interact with all of our hospitals and our hospital clients. We travel a lot. We love coming to places like Crockett. That's sort of our bailiwick, if you will. We're not really the big metropolitan folks. But we do have services, everything from financial improvement, operational improvement. We get into a lot of regulatory and quality support that's there. as well as strategic visioning in those areas of physician development, recruitment, etc. All right? What we thought would be really good is to show you a few case studies of the hospitals that we work with. Sometimes that allows you to get a little more visual of the kinds of things that we're doing, and Wilson's going to do that for us.
Before we